So now I'll do a quick introduction for Dr. Joel Gingerich, who's also done a few of these talks for us and has been affiliated with Kidney Cancer Canada for a number of years, and really pleased that he could be here this evening. He's a medical oncologist with Cancer Care Manitoba. He's also an assistant professor at the University of Manitoba. He's the chair of the Pain and Symptom Disease Site Group at Cancer Care Manitoba. So he's a very busy person. Medical director for the Community Oncology Program. He authored many scientific publications and abstracts, involved in local, provincial, and national committees to improve the delivery of cancer education and cancer care. He specializes in the treatment of, always struggle with this word for whatever reason, genital urinary malignancies, right? It's not a hard word to say, but for whatever reason, I get really anxious when I see it. So thanks for being with us this evening, and look forward to your talk.
All right, thank you very much for that introduction. It's a real pleasure to be with you today. I'd like to thank Kidney Cancer Canada for giving me this opportunity. I'd like to thank all of you for coming today. It's a real privilege to be able to take care of patients that have cancer. My experience in dealing with patients with cancer has really changed me in many, many different ways and has made me a better person. So for that, I'm very thankful. What I thought I would do is spend about 20 minutes, give or take, talking about an update on the treatment of patients that have advanced kidney cancer. Dr. Drachenberg talked about the surgical role of treatment for kidney cancer. I'm going to spend my time talking about patients that have cancer that isn't amenable to complete surgical resection. That is where the cancer is spread and surgery by itself isn't able to get rid of it completely. And as Dr. Drachenberg mentioned, in the last 5 to 10 years, there's really been a significant change in the way that we treat kidney cancer. And the options we have available now are much different and much better than what we had 5 or 10 years ago. So, in order to sort of set up our conversation on how these treatments work and why we use them, I thought I'd give a little bit of background on the rationale for treatment, why these treatments are effective. I'm going to spend some time talking about an approach to the first-line treatment of patients with advanced or metastatic kidney cancer, and then I'm going to end by talking about a general approach to the treatment of patients for second-line treatment for kidney cancer. And in 20 minutes, it's impossible to talk about all the different nuances about treatment, so I'm going to give sort of a general overview, and an individual's case may be just a little bit different than this overview based on their specific characteristics. So, just as some background, if we look at the cancer statistics for 2013, kidney cancer is going to be the 8th most common cause of cancer in Canada. It's just under 6,000 people are going to be diagnosed with kidney cancer this year. Unfortunately, about 1,700 patients are going to lose their life this year from kidney cancer, and it's going to rank the 12th most common cause of cancer death in Canada. If you look at the statistics in Manitoba, that works out to be about 150 males that are diagnosed with kidney cancer this year and about 75 females. And the incidence of kidney cancer in Canada has been increasing over the last few years. Now, not every kidney cancer is exactly the same. If we look at the subtypes of kidney cancer, the most common subtype of kidney cancer is clear cell kidney cancer, or clear cell renal cell carcinoma. This represents about 75% of all kidney cancers that have been that are diagnosed. And then there's a variety of other types that are much less common, like papillary kidney cancer, chromophobe, oncocytoma. There's a variety of different ones. This is really important because most of the studies that have looked at our modern treatments for kidney cancer, at least initially, have focused on the clear cell subtype. And so we have the most evidence for treatment in the clear cell subtype, and I'll show you when that's not quite the case with some of the studies that have been done. Now, as I said, in the last 5 to 10 years, there's been a big change in how we treat kidney cancer, and it's come by a better understanding of the underlying molecular architecture. And I thought I'd just briefly go through this. So there's a protein that's present in a normal kidney cell called the hypoxia-inducing factor alpha, or HIF alpha. When that's present in a kidney cell, it diffuses to the DNA where it causes proteins to be produced. And some of these proteins are proteins called vascular endothelial growth factor, or VEGF. And when that's present, it diffuses to surrounding blood vessels, causes those blood vessels to grow, And that leads to increased nutrient and oxygen delivery to the kidney cell, and allows it to grow. Now, in a normal kidney cell, this is highly regulated. So when the oxygen level is normal in the kidney cell, there's a protein that's present called von Hippel-Lindau protein. And when that protein is present and active, it takes hypoxia-inducing factor alpha and breaks it down. And when you break it down, that means that there aren't those proteins that are being produced that stimulate blood vessel formation. And you get decreased nutrient and oxygen delivery to the kidney cell. On the flip side, when the oxygen level is low in a kidney cell, this von Hippel-Lindau protein becomes deactivated. And when it becomes deactivated, you get a buildup of this hypoxia-inducing factor alpha. And it's like a switch on a light switch. When you turn it on and the light starts producing light, except it stays on. And when it stays on like this, then you have production of proteins, increased production of proteins, which lead to increased blood vessel formation, increased nutrient and oxygen delivery to the cell, and allows the cell to get back into the normal oxygen level. Well, it was determined that between 70 and 90% of kidney cancers that had clear cell subtype had a defect in this von Hippel-Lindau protein. And so essentially what happened is that the light switch was turned on, but it stayed on all the time. So you had a buildup of this hypoxia-inducing factor constantly, and it would drive increased protein production, which would stimulate increased blood vessel formation, which would allow increased nutrients and oxygen delivery to these kidney cancer cells, and allow the kidney cancer cells to grow. And so targeting this pathway with a protein that could, or a drug that could stop this from happening, made a lot of sense. Now, in order to tell you how these treatments work and how effective they are, I have to tell you some statistics about how they work, or how effective they are in clinical trials. And so what I need to say before we go into this is that these are just numbers and statistics. And an individual person may do very different than what these numbers that show up on these studies show. Half the patients are going to do better than these numbers. Some of them are going to do much better, and some patients, unfortunately, are going to do worse than these averages that are showed, that I'm going to show. So the first drug that really changed our treatment is called Sunitinib. This was published in 2007, and it showed that in a large randomized controlled trial with 750 patients who all had clear cell subtype, and the vast majority of them had good or intermediate risk disease, and I'll define what that is in a little bit. But what they found is that the group that got Sunitinib did much better than the group that got our old treatment called interferon. And so much more people in the Sunitinib arm had a significant tumor shrinkage. About 50% of patients had a significant shrinkage in their tumor with Sunitinib. A much higher percentage of that had some shrinkage or at least stabilization in their tumor. They found that about 3% of patients that got this drug had a complete response to treatment, so that the cancer completely went away. And we've had a few patients where this has been the case. They also noted that the time that the tumor was stabilized before it began to grow was much longer in the group that got Sunitinib than the group that got the interferon. It was 5 months in the interferon group, and it was 11 months in the Sunitinib group. And they also found that patients that got Sunitinib lived longer than those that got the interferon. And the difference between the two arms is about 5 and just over 5 months. Now, we think in real-life practice that this difference is actually bigger than what showed up on this clinical trial. And the reason for that is that patients that were in the interferon group, once there was evidence that their cancer was growing, were able to switch to the Sunitinib group and get the Sunitinib treatment. And so that made it difficult to see how long each group was alive. And so we think that this difference in survival between these two arms is actually bigger than what showed up in this clinical trial. Now, as I mentioned, not everyone's going to do the same with their kidney cancer. Some patients are going to do much better than the average, and unfortunately some patients are going to do worse. And so we use some markers to give us an understanding of how someone might do. And if you look in the literature, you'll come up with different risk markers or risk factors for patients that have kidney cancer. And these are just an example of 6 known risk factors for patients with advanced metastatic kidney cancer. If patients are having a lot of cancer symptoms, that's a risk factor. If it's been more than a year, or I should say less than a year from the time that they were diagnosed to requiring treatment, that's a risk factor. And there's a number of other blood tests that we'll look at, common blood tests like what the hemoglobin level is, or what the calcium level is, or what some markers in the immune system are. And we can use these risk factors to give us an understanding of how someone might do with their kidney cancer. So for instance, if someone has no risk factors, we say that they have favorable risk disease. If someone has 1 or 2 risk factors, they have intermediate risk disease, and if they have 3 or more risk factors, they have poor risk disease. And as you can see on the blue line, those patients that have favorable risk disease can do very well. And if you look 2 years out from their diagnosis, about 75% of them are alive and doing okay. And if you follow this line out, even 3 or 4 years down the road, there's a significant portion of patients that are doing well. Likewise, if you have intermediate risk disease, they don't do quite as well, but still 55% of those patients 2 years down the road are alive and doing okay. And a significant portion of them, 3, 4 plus years down the road, are doing all right. Patients that have poor risk disease, where they have multiple risk factors, tend to do worse. Now, Sunitinib does have some side effects. These are some of the common side effects that we see in patients that are treated with Sunitinib. It can cause low blood counts in most patients. Usually this is mild, but sometimes it can be significant or severe. It can cause some mild kidney damage. Usually it's not enough to make us stop treatment though. It can cause diarrhea, it can cause tiredness, cause increased blood pressure, which sometimes needs to be treated. It can cause nausea and vomiting, it can cause rash. Sometimes it'll cause some thyroid dysfunction. It can cause nosebleeds occasionally, and some patients will have some damage to their heart. Usually this is mild, and once you stop the treatment, it goes away. Most patients in general tolerate this treatment fairly well. Now, since Sunitinib became available, there's been a number of other drugs that have looked at targeting the same pathway, targeting this blood vessel pathway. And I've listed some of them here. Sorafinib, bevacizumab, Pazopanib, Tivozanib, Axitinib, all big long names that have nibs at the end of them. They haven't been, in general, compared head-to-head, although I'll show you in one case where it has been. But we think that all of these drugs have activity. They all cause the cancer to shrink, they all cause it to stabilize for a while, and they all have similar outcomes when you look at the groups of patients that have how long they're alive with treatment. So generally speaking, most places across the country, Sunitinib is our first-line treatment just because it's been around the longest, we have the most experience with it. But any one of these drugs would be adequate. Now, as one might expect, there's other pathways that are involved in patients that have kidney cancer, and this is just an example of another pathway that we think is important in patients with advanced kidney cancer. You can have a protein that binds to a receptor on the kidney cancer surface, which activates it, which then activates a whole bunch of other proteins, which end up causing changes at the DNA level, which produces proteins that stimulate the cell to grow. Now, it turns out you can target some of these proteins, and specifically you can target this one called mTOR. And so there's been drugs that have been developed that specifically target this pathway, targeting this protein and trying to shut off this pathway that is activated in patients with kidney cancer. So that leads to another drug that we'll use in patients with advanced kidney cancer called Temsirolimus. This was also a large randomized controlled trial that had over 600 patients in it. Unlike the group that had Sunitinib, most of these patients had poor risk disease, meaning they had multiple risk factors that we talked about on that previous slide. And unlike Sunitinib, patients that had non-clear cell tumor histology could also be included in this study and represented about 20% of it. What they found was that patients that got Temsirolimus did better than the group that got interferon. Some patients had tumor shrinkage, although it wasn't as high as with Sunitinib. They found that patients that got Temsirolimus, the tumor was stabilized for twice as long as the group that got interferon. And they also found that patients that got Temsirolimus lived longer than those that got interferon. You can't compare these numbers with the Sunitinib numbers because it's looking at a different population. But this showed us that this drug has significant activity in patients that meet these criteria that they use in this study. And so this is a drug that we will use in selected patients. Now, the side effect profile for Temsirolimus is a little bit different than with Sunitinib. You can get fatigue, you can get rash, you can get low blood counts, you can get nausea, you can have decreased appetite, diarrhea. But it can also cause other things like increased cholesterol, or I should say increased lipid levels within the body, and increased sugar levels, along with mouth sores. So if we take all this information and we look at how we treat kidney cancer in Canada, this comes from a 2013 Kidney Cancer Consensus Forum update that took place earlier this year. And it's recommended that patients with advanced or metastatic kidney cancer be broken down into those that have good or intermediate risk disease, where we would use a drug that has proven benefit from a randomized controlled trial, like Sunitinib, although as we talked, there are some other ones that have shown benefit. Now, and this is based on the best evidence that science can give us right now. Sometimes, though, patients have low burden of disease or they're having no symptoms. And if we give them treatment, it's going to cause them to have some symptoms. So sometimes we will think about observation, just watching it closely until there's evidence that it's growing or causing a patient trouble before starting treatment. In patients that have poor risk disease, based on the study that I showed you, we'd consider using Temsirolimus. But we'll also sometimes use Sunitinib in this population, even though it wasn't specifically studied in patients that had poor risk disease. So these are the options that we would think about in someone who comes to our office now in 2013. Now, this is the first study that compared two VEGF or blood vessel targeting therapies head-to-head. And this was a non-inferiority trial, so what they're trying to do is to see if one was better than the other, to make sure that they were both about the same. And what they found was that the group that got Pazopanib was very similar to the group that got Sunitinib in terms of their outcomes. So tumor stabilization, how long patients were alive, how much tumor shrinkage there was very similar between these two arms and wasn't statistically different, apart from a little bit higher likelihood of having significant tumor shrinkage with Pazopanib compared to Sunitinib. But what they did find was that in this study, patients that got Pazopanib tended to have improved quality of life. And they looked at a variety of different quality of life forms. And what they found was that group that got Pazopanib tended to have less fatigue, less hand-foot syndrome, and this tends to be where you get a rash or blisters on your hands and feet, inflammation within the mouth, blood vessel suppression, or kidney damage. But patients that got Pazopanib did have some other side effects that were a little bit higher than the group that got Sunitinib. And those included higher risk for some liver dysfunction, more weight loss, and more hair loss or hair color changes. So based on this information, we can say that Pazopanib is very similar to Sunitinib because it's been compared head-to-head and has a similar efficacy, but it has a little bit of a different side effect profile, and quality of life may be a bit better with Pazopanib. So based on this information, and with Kidney Cancer Canada's input, the Pan-Canadian Oncology Drug Review in 2012 recommended that Pazopanib should be considered for patients who are not able to tolerate an effective dose of Sunitinib. And so that's the indication that's approved for use in Manitoba. And so we will think about switching patients from Sunitinib to Pazopanib if they aren't tolerating the Sunitinib very well. It remains to be determined if this is a medication that will supplant Sunitinib in general first-line use. Now, just to end, what about second-line therapy for patients that have advanced kidney cancer where the first-line treatment with Sunitinib has lost its effectiveness? This is a randomized controlled trial that looked at a drug called Everolimus. This also targets the mTOR pathway. And they compared it to a group that got a sugar pill or a placebo. All these patients had previous exposure to Sunitinib or Sorafinib, which is another blood vessel targeted agent, or both of them. And what they found was that the group that got Everolimus did better. Everolimus was able to stabilize a tumor, preventing it from growing, for more than twice as long compared to the group that got placebo. This study was not able to show that patients lived longer with Everolimus, but again, that might have partly been because patients that got placebo were able to cross over and receive Everolimus once there was evidence that their cancer was growing. Just like in the first-line setting with Sunitinib, you can tease out some patients that will do better with Everolimus and some patients that won't, based on some risk factors. And I just wanted to highlight that there are some patients that have progressed on first-line treatment who get our Everolimus, who will do very well and can do well for quite a long time. There's one other study that has looked at second-line therapy in a randomized controlled trial setting. It was this study that compared two blood vessel targeting agents. A newer one called Axitinib, which was thought to be a little bit more potent than some of the other ones, and an older drug called Sorafinib. What they found in this study, and all these patients had been on prior treatment, was that both drugs had activity, but the patients that got Axitinib looked like they did a bit better. They're more likely to have a significant tumor shrinkage, more likely to have tumor stabilization for longer, and just like with the other study, there wasn't a difference in overall survival. But these patients tended to better in terms of these other factors. And so based on all of this information, if we look at the 2013 Canadian Consensus Form for treatment in the second-line setting, based on the best scientific evidence that we have, patients that have been on a prior drug targeting the blood vessel pathway, like Sunitinib, could receive Everolimus or Axitinib. Generally, we have been using Everolimus. That may change. We have some patients that have been on Axitinib, and both of them seem to be good options. We don't know right now, at this time, which one of these two is better. They haven't been compared head-to-head. In settings where we can't get these drugs available, we'll consider using other targeted therapy that we haven't used before, but the evidence behind that is less. In patients that have been on a prior mTOR drug, like Temsirolimus, we don't really know what the best treatment is in that setting. And so based on less than the best evidence, we'd consider using a targeted therapy that hadn't been used before. Now, there are lots of studies that are ongoing right now looking at patients with advanced kidney cancer, and so I expect that the field is going to significantly change in the next months and years. And I think it's a very exciting time for treating patients with kidney cancer. And our options are much more than we used to have, and I think they're going to expand in the coming months and years. Cancer Care Manitoba has a strong track record in dealing with clinical trials involving kidney cancer. I've listed some of them here. We currently have a study that recently opened looking at evaluating the risk of heart problems in patients that are receiving Sunitinib. So we'll try and get some of our patients onto this study. So just to conclude, treatment of metastatic kidney cancer significantly improves and is able to cause the cancer to shrink and stabilize the tumor longer than our older treatment, and causes patients to live longer. There are many more options than there used to be, and I think there's going to be even more in the future. What we need to determine, I think, in the coming future is how to best or optimize the sequence of these treatments. Which one's best to go first, which one's best to go second, and so on. So with that, I'm going to end. Thank you very much for your attention.